Alpha blockers. Phenoxybenzamine and phentolamine are both non-selective alpha blockers, meaning they can block both alpha-1 and alpha-2 receptors. Phenoxybenzamine is an irreversible competitive antagonist, meaning it binds alpha receptors permanently, while phentolamine is a competitive reversible antagonist. The famous vignette about phenoxybenzamine is always to give it preoperatively before surgically removing what type of tumor? A pheochromocytoma. Remember, from your endocrine chapter, a pheochromocytoma secretes catecholamines causing episodic hypertension. Now, because of its reversibility, phentolamine is given to help temporarily block alpha receptors in patients that accidentally eat tyramine foods like cheese and wine while taking an MAO inhibitor. The side effects of these drugs are directly related to their mechanism of action. If you excessively block alpha-1 receptors, you can potentially cause a significant decrease in the total peripheral resistance and a decrease in blood pressure. Remember, blood pressure equals cardiac output multiplied by the total peripheral resistance. This hypotension can trigger the baroreceptor reflex and result in reflex tachycardia. Alpha-1 blockade can also cause orthostatic hypotension, aka a drop in blood pressure upon standing, which can lead to dizziness and a headache because the brain is being hypoperfused. The selective alpha-1 blockers all end in osin. Now, I wish all drug names were this easy to remember. So just like our non-selective alpha blockers, excessively blocking of the alpha-1 receptors can cause a drop in peripheral resistance and blood pressure, leading to hypotension and the risk of hypoperfusion of the brain. Now, these drugs were designed with the goal of relaxing smooth muscle within the prostate and the neck of the bladder to help men with benign prostatic hyperplasia urinate. The alpha-1 antagonists, such as tamsulosin, prevents the smooth muscle around the prostatic urethra from contracting. This allows the urethra to have a larger diameter, allowing men with BPH to pee without dribbling. And do you remember what causes benign prostatic hyperplasia? The potent androgen 5-dihydrotestosterone, which stimulates cell proliferation of the lateral and middle lobes that surround the prostatic urethra. Mirtazapine is primarily used for depression because by antagonizing alpha-2 receptors, there is no negative feedback on the release of monoamines. This results in an increase of the release of neurotransmitters such as norepinephrine and serotonin, making your patient feel happy. One of the side effects is an increase in appetite, which could actually be beneficial when treating elderly or anorexic patients with depression. So now we are about to see what happens to heart rate and blood pressure when you give the alpha blocker, phentolamine, after giving epinephrine or after giving phenylephrine. Let's start with epinephrine. Remember that epinephrine stimulates beta-1 receptors in the heart, leading to an increase in heart rate, as well as cardiac output, which leads to an increase in systolic blood pressure. Notice how epinephrine causes a net overall drop in diastolic pressure due to stimulation of beta-2 receptors on blood vessels. Recall that beta-2 agonism causes vasodilation. The strength of this effect is countered a little bit by epinephrine's weaker alpha-1 activity causing vasoconstriction. If we give an alpha blocker like phentolamine, we completely eliminate this vasoconstriction. And what do we have now? Unopposed beta-2, which as you can see causes a larger drop in a diastolic blood pressure and completely flips the net effect from an increase to a net overall drop in blood pressure. Now, what do the baroreceptors think about this? They do not like it and will trigger a reflex tachycardia. Now let's compare with the other graph. First, do you remember what receptors phenylephrine work on? That's right, it is a pure but weak alpha-1 agonist. So we can see that the alpha-1 mediated vasoconstriction raises the diastolic blood pressure. The baroreceptors sense this increase in pressure and cause a reflex bradycardia. Then, when we give our alpha blocker phentolamine, well, it basically wipes out and suppresses all the effects of the drug phenylephrine.